same thing with ECMO. It's really not 100% sure what the role is, frankly, of ECMO and diaphragmatic hernia in terms of a proven, randomized utilization of the technology. But we're, as a physician, we're trying to do the best we possibly can for this critically ill baby sitting under our eyes. So you start grabbing at those things, but they're really largely unproven because the numbers are small. And the long-term follow-up, which I think is a real big issue for us, doesn't exist. So yeah, great. There's an incidence of chest wall problems these kids have. There's a higher incidence of scoliosis than there is in the population as a whole. So these are all things that, and it may be, who knows, it might be a worse problem with scoliosis with the abdominal flap. So you might be trading recurrence off for something else. I don't know. It's a short answer.
Yes, I was wondering if you have any data or experience operating on eventration of the diaphragm?
The registry looks mostly at hernia as a whole. I have a lot of experience operating on it.
But an eventration? And my son is 2 years old and he's not operated yet. In Mexico, they keep telling us to wait. So, is that true? Should I wait?
It really depends. Our indications for operating an eventration are mostly we have respiratory difficulties and frankly, mostly on the ventilated patients, we can't wean off the ventilator. And that big floppy part of the diaphragm, it also depends on how big the eventration is. If we're not growing, if we have problems with exercise tolerance, but you can have a small eventration that really doesn't impact on much of anything. So like everything else in medicine, it's very variable and will depend on the situation.
Thank you.
Otherwise?
Just a question. Do you find that some of the hospitals may be a little wary of providing data because, and I don't mean to make this sound crude now.
No, people are very willing to share their data, both their successes and their failures. And I do this because it's anonymous. They submit as an anonymous center number, and I don't release any individualized data. I don't release any aggregate center data except to the center. And the centers get reports where they can see how their center data compares to the CDH registry at large. But I've been very impressed. People are very willing to share their data. I think everybody wants to figure out how to take care of these kids.
Yeah. Well, because one thing I think would be useful to us as parents, and it's probably why the hospitals don't publish it. If you have the short window, between the 20 weeks when you find out and when your baby's born to pick which hospital you're going to go to. And what we've found, at least talking to other parents and everything, is they get a lot of misinformation. As a general public, we'd like to go, if it's your baby, you'd like to go to the place that has the best track record of doing this. And, it'd be nice if there was a scorecard, grading all the hospitals.
These centers see small numbers, okay? Even the big centers, maybe 15 cases a year. And if they have a bad run, they have a number of babies with very large defects or a number of babies with additional complications like cardiac defects, their statistics for that year or even 2 years may look pretty bad compared to other centers. They've had a real tough go. And there are other centers that aren't ECMO centers or that just happen to have a number of babies in a row that have very small defects that go home very quickly, and their statistics are going to look pretty good. And I can tell you that there are some centers that say, gee, our statistics are great. They have a bad year or two, and all of a sudden they're saying, geez, we're not as good as we thought we were. And it's because this mix of babies that we can't get the literature to tease out is the problem. How many of the babies with agenesis a year do you see, and how do you do with those? And how many babies that are primary repairs that don't need ECMO do you see? And that's the mix that centers don't typically tell, or that isn't available, just because nobody's been looking at it.
Yeah, because even when you visit a hospital and you ask them what their survival rate is for that hospital, they usually won't give it to you.
They frankly usually don't know. And most of the time they don't track it that well. And so as Pam has talked about, one of the key items was developing risk stratification. The medical literature didn't like the criteria, hence we already know the data, but we now have to create a structured mechanism of what people can look at and say that's what this is. But we already know that the bigger the defect is. So she's created reports for each center that give registry-based outcomes by size of the defect and then compares that to that individual center. It's one of the reasons that people are interested in it, because it gives them risk-adjusted outcomes compared to this broad group. So how are you doing? And in terms of, but there is one center who reports 88% survival in diaphragmatic hernia. They don't do ECMO. They don't have any patients with big defects. And so they have what you might say, oh, I'm going there, right? They have this great survival. The other problem is that, you know, as she's alluded to, because the numbers are small, statistics can change very quickly. And all it takes is a couple of kids with a bad heart problem and a big defect, and all of a sudden, you know, you've had a bad run. I mean, to be perfectly frank, the last two infants with diaphragmatic hernia in my institute both died. And I've got a lot of experience taking care of these babies. So this remains a very difficult problem, and there is nobody today who's got the best solution for these really big defect kids, these very, very high-risk kids. The small defect ones we've got for you.
How do you determine the severity of the defect? Is it from the size of the hole, or for how much is up inside the hole, or?
Well, we think they're linked, you know, and well, I think they're linked, and we get to the underlying mechanisms and stuff become a different problem. But clinically, the short answer is it's size. You should look at it, okay, how is it? Conceptually, one of the older animal models was as a lamb model. People still use it, it's just more expensive. But you can create the hole, and then the severity of the animal's lung problems relate to how big a hole you make and how much gets put up. So it's simplistic, and the scientist in me recognizes it's simplistic, but the surgeon in me really likes it. And that is, the bigger the hole, the more stuff can get out there, and the quicker it can get out there. You know, I mean, if there's nothing at all, then it's a free pass, so to speak. That may not be, I recognize that may not actually be the case, but it sure makes sense to me. And there's no question that these extreme large defects definitely have the worst.
But I mean, isn't lung-to-head ratio still the gold standard for severity?
Yeah, it is, but it depends on the institution, it depends on the time, and there's a lot of controversy with the LHR as well, because it's institutional dependent. And the problem is that in centers, well, you know, like ours, if we do enough of them, then you say, okay, I'm pretty comfortable that this week that's what this number means. That's not necessarily translatable across the country. And what you can't have everybody traveling all over the country, you know, just to one spot. That doesn't make any sense. So, so the answers we're looking at, a lot of other things people are looking at as well. MR is probably going to turn out to be pretty useful, and we can do prenatal estimations of lung volumes as well. But the other problem we found is that none of these predictors, one of the things that I was interested in is, can I predict futile therapy for everybody, for the family, for the child? If I've got a kid who's 1 day old and there's no hope for survival, the answer is I can't do that. None of these can. We can predict high risk, you know, but I can't predict. We have kids who have a 90% predicted mortality who are alive, and there are patients who have a 90% predicted chance of living who are